Actually, as you all know, that the chest X-ray is one of the simple procedures in the radiology department, and is frequently used because of its relatively low cost. Meanwhile, it's very sensitive and provides an excellent resolution. And in order to interpret the chest X-ray, we have to know the criteria of the optimal chest radiograph. And these criteria are concerned with the accurate patient position, like this one, adjustment of the distance between the film and the tube, X-ray tube, instructing the patient to have a full inspiration before the radiograph is obtained, and adjusting the radiographic factors according to the patient size. Then this is the most common, most famous chest radiograph in the radiology practice, which is known as the posterior view. And actually we name the radiograph according to the direction of the entrance of the X-ray into the human body. If the X-ray is entering the back of the patient, this is known as posterior. If the patient is facing the X-ray tube, we call this film an anteroposterior film. Then this is the standard view, which is the posterior view. Then what happens if the patient is facing the tube? This is the posterior view, and this is the anteroposterior view. Whenever this patient is facing the tube, the heart will be away from the X-ray film. Then you expect some magnification of the cardiac shadow. And this is the same patient. This is the posterior view, and this is the anteroposterior view. You can feel some magnification in the cardiac shadow, which does not mean that the heart is enlarged. Also, whenever you radiograph the patient while in the supine position, you expect some magnification in the cardiac shadow because of the elevation of the diaphragm. Then this is the posterior view, and this is an anteroposterior view in the supine position. The supine position is usually obtained for the patients in the ICU or the casualty sections. Then whenever interpreting the chest X-ray of these patients, we should consider that the cardiac shadow will be magnified because of two conditions. The heart is away from the film, and the patient cannot take a full inspiration. Then the diaphragm will be elevated, and you expect some flattening of the cardiac shadow. The lateral view is named according to the site which is near to the film. This is the left lateral view, and you usually perform the lateral view according to the data seen in the frontal view. If the pathology is in the left lung, you should have the left lateral view. If the pathology is in the right lung, you should have a right lateral view. In the frontal view, normally you should expect some difference between the level of the diaphragmatic copula on both sides. The right copula is usually higher than the left copula by a distance from 1 to 3 centimeters. Then if you look to the chest X-ray like this one, and you can see that the right copula is relatively higher than normal, and the highest point of the diaphragm is shifted to the lateral chest wall. If you see this finding, you suggest that this patient will have some fluid underneath the lung, what we call subpulmonary effusion. Then in order to confirm this finding, you put the patient in this position, which is known as the right lateral decubitus. And the X-ray tube is behind the patient, the film is in front, then the fluid from underneath the lung will flow into the pleural recess. Nowadays, we do not usually need this position, and it was replaced by detection of the subpulmonary fluid by ultrasound or even by CT scan. Anyone can look to this chest X-ray and he feels that this is not an optimal radiograph because you cannot see the details of the lung, and you can see the dorsal spine through the cardiac shadow. This is an overexposed film. That's to say the patient has received an X-ray dose above or more than required. And the opposite is when the patient receives a lower X-ray dose, then you can see veiling of the lower lung zones. You cannot see the costophrenic angle, and you see hazy appearance of the hilar shadows. Then this is the normal or optimally exposed radiograph. where you can see the details of the lung, and you can see the cardiac shadow, you can see the costophrenic angle on both sides. Then how to know if the patient had a full inspiration before he was radiographed? Normally, if the patient had a full inspiration, then the diaphragm will be seen at the level of the 10th rib posteriorly. How to count the ribs? You go to the first rib, this is the first rib, and this is the second one, this is the third, fourth, fifth, sixth, and so until you reach the 10th rib. If you see the diaphragm at this level, you know that the patient had a full inspiration, and this is an optimal quality radiograph. What happens if there is no full inspiration, or if the patient was exposed in the expiration? Then you can see elevation of the diaphragm and the flattening of the cardiac shadow as well, and you may misinterpret this as a left ventricular enlargement, for example. And in the lateral view, whenever you see this lateral view, you can see that the upper dorsal vertebrae are bright and the lower dorsal vertebrae are black, because the upper dorsal vertebrae are superimposed by the shadows of the shoulders of the patient, while the lower dorsal vertebrae are superimposed by the shadow of the lung bases. Then if you see the opposite, and you can see that the lower dorsal vertebrae are bright and the upper dorsal vertebrae are relatively black, then you know that there is some pathology in the lung base that has been superimposed on the dorsal spine. And if you go to the frontal view, and you can see that there is a mnemonic consolidation in the right lung base that has been projected posteriorly. If you look to the chest X-ray, how can you know that the patient was adjusted before radiograph? And you look to the spinous process of the dorsal spine, and you measure the distance between the spinous process and the medial edge of the clavicle on both sides. This distance should be equal on the left side, equal to that on the right side. Then the patient is not rotated. What happens if the patient is rotated? Look at this film. This is the dorsal spinous process, and this is the medial edges of the clavicle. The distance is not equal. Then you can see that one lung is hypertranslucent and the opposite lung is veiled. This is not pneumonia, and this is not emphysema. This is just because of the rotation of the patient before the radiograph. And if you see a lesion and you would like to locate the site of the lesion to a certain part of the lung, we all know that the most or the highest point in the lung, the highest part in the lung is the apex. And the area opposite the hilum is known as the middle lung zone. And the upper lung zone is this region between the apex and the middle, while the lower lung zone is below the middle lung zone until you reach the diaphragm. This is the area of the upper lung zone, and this is the region of the lower lung zone. But you can exactly locate the site of the lesion to a certain lobe if you have a lateral view, because on the left side you have the major fissure, on the right side you have the major and minor fissure. Then if there is a lesion here, you can say that this is the upper lobe, this is the middle lobe, and this is the lower lobe. Here you can see the upper lobe, and this is the lower lobe on the left side. This patient had recent cardiac surgery with sternotomy wire sutures and pleural effusion on the right side. This effusion has extended into the fissures. This is the major fissure, this is the minor fissure, and you can see this is the upper lobe, this is the middle lobe, and this is the lower lobe. Then we should know some words about some of the radiology terms that we use in the radiology reports. The first sign is known as the silhouette sign. And the silhouette sign means that there is an opacity in the lung that has masked one of the cardiac borders. Then if you try to identify the right cardiac border through the opacity, you cannot. And this means that this opacity is adjacent to the heart. And the heart is an anterior structure, then this opacity is anteriorly located. And the anterior part of the right lung in this area corresponds to the middle lobe. Then you know that this opacity should be present in the middle lobe without the need for the lateral view. Then if you see an opacity like this one, and you try to follow the cardiac shadow, and you can easily follow the cardiac shadow, then this opacity is not adjacent to the heart, it is posterior to the heart, and that's to say it is in the lower lobe. When you can identify the cardiac shadow through the opacity, this is known as silhouette negative. And whenever you cannot identify the cardiac shadow through the opacity, this is known as silhouette positive. Then this is a silhouette negative sign where you can see an opacity, but you can still identify the cardiac border. This means that this opacity is located in the lower lobe posteriorly, and this finding is confirmed by the CT scan, where you can see the opacity posteriorly located. This is the cardiac shadow, and this is the dome of the diaphragm. The second sign is known as air bronchogram. By air bronchogram, we mean that there is an opacity in the lung, and inside the opacity you see multiple air-filled bronchi. Whenever you see this very specific sign, you know that you are dealing with a pulmonary parenchymal disease. And this disease is of alveolar origin, and this disease is characteristically a consolidation. Then whenever you see this air bronchogram, you know that you are dealing with these three facts: pulmonary pathology, alveolar in origin, and its nature is a consolidation. Then we have four terminologies in the chest. The first one is what we call the pulmonary nodule. Pulmonary nodule is a well-defined lesion that is less than 3 centimeters in diameter. The pulmonary mass is a well-defined lesion that is more than 3 centimeters in diameter. The pulmonary patch is an ill-defined lesion containing air bronchogram. The pulmonary cavity is a well-defined lesion containing air. And these are the major items in interpreting the chest X-ray. Now, knowing the optimal quality radiograph, the criteria of the optimal quality radiograph, and the clinical data of the patient, and if we can have the previous films, we'll start the interpretation of the chest X-ray. Then, in order to interpret the chest X-ray, we have to differentiate between two very big issues: the focal lung lesion and the diffuse lung pathology. The focal lung lesion means that you have a single or double or triple lesions in the lung, but the rest of the lung is free. While the diffuse lung pathology means that both lung fields are almost completely infiltrated by a pathology. Then if we decided that we are dealing with a focal lung lesion, we have the three types of focal lung lesions. The pulmonary nodule, which is a well-defined lesion less than 3 centimeters in diameter. The pulmonary mass, which is a well-defined lesion more than 3 centimeters in diameter. The patch, which is an ill-defined lesion containing air bronchogram. And the cavity, which is a well-defined lesion containing air. Then we'll start the interpretation. And we will assume that we are dealing with a pulmonary nodule or nodules. You look to the chest X-ray and you see a well-defined lesion less than 3 centimeters in diameter, and you decided this is a nodule, and you would like to know the differential diagnosis. I select the most common pathology appearing in the lung as a nodule, and they are 6. And I will let you to suggest any more categories underneath this title. First, we have the tuberculoma, the hamartoma, the bronchogenic carcinoma, the metastasis, the pulmonary arteriovenous malformation, and the hydatid cyst. In order to reach the differential diagnosis, we all know that metastases are usually multiple, and metastases are the most common multiple pulmonary lesion in the lung of the pediatric age and of the adult age. Then whenever you see multiple lesions like this, you diagnose metastasis as a first possibility. But metastasis can be solitary, and you cannot know that this is a metastatic deposit unless you know that the patient had a primary malignancy. And if you know the history and you see a pulmonary nodule in a patient with breast cancer, for example, and you diagnose this nodule as metastasis. Then metastasis can be diagnosed by the plain X-ray and by CT on the basis of multiplicity. And multiple lesions are highly suggestive of metastatic deposits. Then if you see a pulmonary nodule, and this nodule has a smooth margin and it contains calcium, then you know that this nodule may represent one of two, either tuberculoma or the hamartoma. And the tuberculoma is usually located in the upper lobes. Hamartoma can occur anywhere in the lung. But you don't have to differentiate both lesions on radiographic basis. And you can see this is a smoothly marginated nodule with internal calcification representing a tuberculoma. And this is a smoothly marginated nodule with internal calcification representing a hamartoma in the lower lobe. And this is a classic appearance of a hamartoma in the lung by CT scan, and you can see the smooth margin and the characteristic popcorn calcification inside the lesion. Then whenever you see a nodule with a speculated or serrated margin, then you can see this nodule with a speculation of its margin. This is the malignant nodule, which represents the bronchogenic carcinoma. And because the bronchogenic carcinoma invades the surrounding lung, it can have this very characteristic appearance in the chest X-ray as well as in the CT scan. And this is a classic appearance of a bronchogenic carcinoma with a speculated margin in the chest radiograph. Then this is a classic appearance of a bronchogenic carcinoma on a CT scan. The edge is very characteristic. It is a speculated margin, very highly suggestive of a malignant lesion. Then if you see a nodule, and this nodule in the chest containing water, and you cannot know the content of the nodule unless you have a CT scan or ultrasound. If you see the nodule containing water, then the diagnosis is hydatid cyst. And I can safely say that the only nodule in the lung filled with water is hydatid cyst. The only nodule in the lung filled with water is hydatid cyst. Then one may ask about the possibility of an abscess. And this is the difference between the abscess and the hydatid cyst. The abscess has a very thick margin. The margin takes contrast enhancement, and most of the abscesses should contain air. I mean, they are cavitary lesions, not a nodule or a mass. Then this is the hydatid cyst after excision, and you can see how thin the margin of the lesion, and the margin does not take contrast enhancement. This is the hydatid cyst, and this is the abscess. Then this is a nodule containing water. How can you know that this nodule containing water? By comparing the density by the density of the muscle. If it is lower than the density of the muscle, then you know this is fluid. If it is almost similar to the density of the muscle, you know that this is solid. Then the arteriovenous malformation is a nodule that is connected to the hilum by the feeding artery and the draining vein, what we call the vascular pedicle. The vascular pedicle is two lines connecting the nodule to the hilum. And this is the feeding artery and this is the draining vein. And sometimes you can see only one line connecting the nodule to the hilum because the other line is hidden behind the first one. This is also highly suggestive of a pulmonary vascular malformation. And you can see a nodule in the right lung base connected to the hilum by two cords representing a vascular pedicle. And in the era before the CT scan, we used to introduce a catheter in the pulmonary artery, injecting contrast material. Then you can see the feeding artery and the draining vein as well as the AVM itself. But whenever you suspect an AVM nowadays on chest radiograph base, then you use the CT facility, you inject the contrast material intravenously, and you can have this very characteristic appearance. This is the pulmonary vascular malformation, and this is the feeding artery, and this is the draining vein. And if you look to the chest X-ray and you see a pulmonary nodule like this one, and you have to answer 4 questions. What about the age? What about the calcium content? What about the density, water or not? What about the vascular pedicle? If you cannot answer any of these questions, you should have a CT scan. And the CT scan of this case showed the nodule with the classic appearance of a speculated margin, denoting that this is a malignant nodule representing a bronchogenic carcinoma. Then we have finished with the pulmonary nodule with 6 common possibilities: tuberculoma and hamartoma, smooth margin containing calcium. Bronchogenic carcinoma has a speculated margin. Hydatid cyst contains water. Arteriovenous malformation has a vascular pedicle. Metastases are multiple, or if it is solitary, you should know the history of the patient of primary malignancy. Then I will let you to suggest a the nodule number 7 in this list, considering that the nodule you will suggest should be as frequent as to be seen once per year. The nodule you will suggest should be frequently seen in the clinical practice at the rate of once per year. If this nodule is seen at the rate of 1 per year, then I have to consider it, and I have to put into the differential diagnosis and try to separate it from the rest. But if the nodule is very rare, like let's say the rheumatoid nodule, and I have seen only one case of rheumatoid nodule in my clinical practice, and I don't consider the nodule seen on the internet or seen in the books. I mean the nodule seen during the regular clinical practice. Then pulmonary carcinoid, rheumatoid nodule, intrapulmonary lymph nodes, or all these nodules that are not frequently seen in the clinical practice, so they are not included in my list of differential diagnosis. If you know a nodule, please. Good. That's to say, if we are looking to the chest X-ray and you see a pulmonary nodule or nodules, you have only very commonly one of 6, and the differential diagnosis is easy. Now we came to the masses, and you see the mass is a well-defined lesion that is more than 3 centimeters in diameter, and the masses that are common in the lung are only 3. These are the bronchogenic carcinoma, which is large, the hydatid cyst, which is large, and the metastatic deposit, which is large. Then if you see a mass in the chest radiograph like this one, all what you need is to know the content of the lesion. If it is water, this is hydatid cyst. If it is solid, let us go into the differential diagnosis. This is the CT scan of the same case, and you can see that the lesion contains water, meaning that this is a hydatid cyst. Another case, which is silhouette negative, meaning that this lesion is posterior to the heart, and the CT scan showed that this lesion is actually posteriorly located, and it contains water representing hydatid cyst. Then what happens if the nodule is solid, if the mass is solid, and this is the mass on the chest X-ray, and this is the CT scan, which showed that the mass is solid. Then you are in the differential diagnosis between bronchogenic carcinoma and the metastatic deposits. Metastases are diagnosed on the basis of multiplicity or the positive history of primary malignancy. If there is no multiple lesions and there is no well-known history of primary malignancy, then you came to a very important rule which says that the solid mass in the lung of an adult should be considered as bronchogenic carcinoma until proved otherwise. The most common solid mass at all in the lung of an adult is the bronchogenic carcinoma. And then you consider the possibility of bronchogenic carcinoma, and one may say that, but this carcinoma contains calcium, and calcium usually means that you are dealing with a benign lesion. I say no. This is true for the nodule, and it's not true for the mass. If you see a mass in the lung, whether it contains calcium or not, whether it has a smooth margin or a speculated margin, you consider it as bronchogenic carcinoma until proved otherwise. Then you see a mass in the chest, and you do a CT scan, and you see that the mass is solid, but it contains calcium, you consider it bronchogenic carcinoma. And you see another mass in the chest, and you do a CT scan, and you see the mass is solid, and you know that this is a bronchogenic carcinoma. Then you see a mass in the chest, and you do a CT scan, the mass is solid, but the patient is known to have renal cell carcinoma. Then you are dealing with a metastatic deposit. And this child has an osteosarcoma. Then the mass in the right lung should represent a metastatic deposit. Then whenever you see a chest X-ray with multiple nodules or multiple masses or multiple nodules and the masses, you should suspect the diagnosis of metastasis. Even if you don't know that the patient had a primary malignancy. Then one may say that the hydatid cyst can also occur in multiplicity, but metastases are far common compared to the hydatid cyst in the lung. And you see, this is metastasis in the case of breast cancer, and this is metastasis in the case of cancer colon. You don't need this history to diagnose these metastases. These are metastases, whatever you know that the patient had a cancer colon or not. Then if you see two lesions like this, the possibility of metastasis should be considered, and also the possibility of hydatid cyst. Then you have a CT scan, then you can see that both lesions contain water. Then you are dealing with hydatid cysts. Then the masses are only 3. The masses in the chest of an adult, because the pediatric age has a certain different rule. And there are three only masses in the lung of an adult: the bronchogenic carcinoma, the hydatid cyst, and the metastasis. Then we came to the batches, and the batches represent an ill-defined lesion containing air bronchogram. And there are only two possibilities: pneumonia and infarction. The difference between both cannot be reached on radiology basis, but is only reached on clinical basis. The patient with pneumonia is feverish with cough and expectoration. Patient with pulmonary infarction has acute chest pain, hemoptysis, and he may have the deep vein thrombosis, which is the source of emboli. And whenever you see a patch in the lung and you don't know the history of the patient, you diagnose pneumonia. Unless you have a positive history of infarction, you can diagnose the infarction. This patient had fever and expectoration with a veiling in the right lung base, and the patch on CT scan after antibiotic therapy, the lesion has cleared. Then the fact that an infarction is triangular in shape, with its base is to the pleura and its apex is to the hilum, is no more valid. The only way to diagnose an infarction on radiology basis is the clinical, and you should know accurate that this patient had the positive clinical history to suspect the possibility of an infarction. But if you see a lesion like this, you should diagnose pneumonia until proved otherwise. If you have the positive history of infarction, then you can diagnose the infarction. Then we came to the cavities, and the cavity is a well-defined lesion that contains air. And this air may be pure air, or air and fluid, or air and a mass. All these are the possibilities for a cavity. A cavity with air only, cavity with air fluid level, and a cavity with a mass. We'll start the differential diagnosis of a cavity with air only. And here you can see the cavity containing air, and the differential diagnosis depends on the wall thickness. If the wall is thick, you have two possibilities. If the wall is thin, you have two other possibilities. Then if you see a lesion with air only and the wall is thick, the first possibility is chronic lung abscess. After the pus has been expectorated and you are left with a cavity with a thick margin containing air. The differential diagnosis will include a breakdown in a bronchogenic carcinoma. And you can see the bronchogenic carcinoma when there is central breakdown and the patient expectorates the shreds of the tumor, then you are left with a cavity with thick margin containing air. What is the difference between both is the inner margin. The inner margin of an abscess is very smooth, while the inner margin of a tumor is very irregular. Then whenever you look to an abscess like this, and you should ensure that the inner margin is smooth. And whenever you are looking to the bronchogenic carcinoma, you can see the inner margin is extremely irregular. And this is the sequence of the development of lung abscess. First, there is minor amount of air and major amount of pus. Then air increase and pus decrease, and you are left in the chronic stage by a cavity which is totally filled with air. It has a thick margin and a smooth inner surface. Then if you have a cavity filled with air with thin margin, if this cavity is located central in the lung, the possibility of nematocele should be considered. If the cavity is subpleural in location, then the possibility of emphysematous bulla should be considered. Then what about the cavity with air fluid level? And this is the regular lung abscess. And you see a cavity with air fluid level, and the surface of the fluid level is straight. But in cases of the fluid level, the surface is wavy, and this is the possibility of ruptured hydatid cyst. Whenever the hydatid cyst ruptured, the daughter cysts try to float on the surface of the fluid level. Then you can see that the surface is not straight, it is wavy, what we call the water lily sign. And this is what we call the water lily sign. And you can see the air fluid level is somewhat wavy. This represents ruptured hydatid cyst, and the straight fluid level represents the abscess. And this is the classic appearance of a ruptured hydatid cyst with wavy internal air fluid level. Then what are the possibilities of a cavity containing a mass? The first possibility, the most common at all, is the fungus. And whenever you have a chronic lung cavity, the fungus may develop inside the cavity, and this is what we call the fungal ball, mycetoma, or aspergilloma. Then what happens if you see a cavity like this, and this cavity has a thick margin with irregular inner surface? Then you know that this is a tumor. And if this cavity contains a ball, it will not make any difference in the diagnosis. This is a tumor, whatever it contains a ball, and whatever, or it does not contain a ball. Then the most common cavity containing a mass at all in the chest is the fungus. And the fungal ball is a very common possibility for the cavity containing a fungus, unless you see that the cavity has a thick margin with irregular inner surface. Then you know that this is a tumor. By this we came to the end of the first talk, and actually at the end of any talk I present to you some of the quiz cases in order to see how much of the knowledge you have acquired. Then before interpreting the chest X-ray, you should first know what is the category you are dealing with. Are you dealing with a nodule or a mass or a patch or a cavity? Then you will start the differential diagnosis. Then we look to this lateral chest X-ray and we see a lesion in the lung base. What do you think of this? Nodule, mass, patch, cavity? Nodule, yes. Which one of the 6 nodules I have mentioned? Yes, very good. This is an AVM malformation because you see the nodule is connected to the hilum by a vascular pedicle. And I have said that the vascular pedicle may be single or multiple or double, because in cases of a single vascular pedicle, the other one is hidden behind the first one. This is a pulmonary vascular malformation. Then what do you think of this? Nodule, mass, patch, cavity? Cavity. And this cavity with air fluid level? Yes, very good. This is a ruptured dilated cyst because the air fluid level is wavy. Nodule, mass, patch, cavity? Yes, cavity with a mass inside. What do you think? Yes, this is a fungal ball, aspergilloma, mycetoma. This is a classic appearance. Nodule, mass, patch, cavity? Patch. Patch without history or with this history? Yes, this is a pneumonia. Very good. Nodule, mass, patch, cavity? Cavity. With air fluid level, and the fluid level is straight. Then you are dealing with lung abscess. Very good. Okay. Nodule, mass, patch, cavity? Mass. And you need the CT scan to know if it contains water or not. And this is the CT scan. Yes, hydatid cyst. Very good. Nodule, mass, patch, cavity? Nodule. Nodule, tuberculoma. Okay? Or you should have a CT scan. Tuberculoma. Or CT? CT. What do you think? Yes, this is a bronchogenic carcinoma because of the speculated margin. And in the plain X-ray, you will feel that this is a smooth margin and it looks benign. But don't do this unless you have a CT scan to confirm the possibility. And it happened that this nodule has a speculated margin representing a bronchogenic carcinoma. Nodule, mass, patch, cavity, metastasis, and you see the patient had carcinoma of the colon. If you don't know this history, these are also metastases. Then nodule, mass, patch, cavity. Very good. Yes, very good. This is a malrotated patient, and you see the spinous process and the distance of the clavicles. This is a malrotated patient. Nodule, mass, patch, cavity. Mass. Yes, and yes, you should have a CT scan, and this is the CT. What do you think? There are only 3 possibilities: hydatid cyst, bronchogenic carcinoma, and the metastasis. What do you think? Yes, then any mass in the lung of an adult and you don't have the history of a primary malignancy, then you should consider a bronchogenic carcinoma. This is solid as compared to the muscles of the chest, and this is a bronchogenic carcinoma. Then nodule, mass, patch, cavity? Cavity. Water lily, very good, and this is ruptured hydatid cyst. Nodule, mass, patch, cavity? Patch. Fever and the cough? Pneumonia, very good. Nodule, mass, patch, cavity? Cavity. Yes, irregular inner margin, diagnostic of bronchogenic carcinoma. Very good. This is a cavitating bronchogenic carcinoma with metastatic lymph node posterior to the superior vena cava. Nodule mass batch cavity, cavity with air fluid level. Air fluid level is straight, then you are dealing with a lung abscess. Nodule mass batch cavity, this lesion is an easy diagnosis because the patient had metastasis in the brain. And the metastases in the brain are commonly coming from the bronchogenic carcinoma. And frequently in the clinical practice, we see patients presenting for first time by brain deposits. And we usually look in their chest and we can see the primary malignancy, which is the bronchogenic carcinoma. Then nodule mass batch cavity, mass. And what is the diagnosis? CT? No, there is a positive history of primary malignancy. Then you don't need the CT scan. This is a metastatic Ewing sarcoma in the chest. Nodule mass batch cavity? Yes, very good. This is an AV malformation because of the vascular pedicle connecting the nodule to the hilum. Nodule mass batch cavity? Bronchogenic carcinoma with typical speculated margin. Very good. Nodule mass batch cavity? Yes, and this is a lung abscess. Nodule mass batch cavity? Nodule? Yes, with calcium. Nodule with calcium. What do you think? Tuberculoma or hamartoma. Being posteriorly located, then you know that this is a hamartoma, and it was a hamartoma. Very good. Nodule mass batch cavity? Mass. This is the CT scan. It is solid. Then the diagnosis is bronchogenic carcinoma. Bronchogenic carcinoma is the most common mass in the chest of an adult. Nodule mass batch cavity? Bronchogenic carcinoma with a speculated margin. This is the CT scan confirming the speculated margin, and this is the bronchogenic carcinoma. Nodule mass batch cavity? Metastasis because of the multiplicity, and thank you very much.